So one of the things that the Bowen technique is renowned for really is working with back pain and things like sciatica. Now often clients will come in and they say, oh, I've been told I have sciatica, or I think I've looked it up on Google or whatever and I think I've got sciatica. And you ask them where the pain is and it's nowhere near the line of the sciatic nerve. So we have to go through various assessments really to try and find out where we're needing to work. We're not diagnosing, we're just looking to see where we do our Bowen work. And as I said before, a lot of the areas that we're trying to work in are the areas which are perhaps not moving. So with lower back pain, for example, and particularly chronic lower back pain, you can get a buildup of stiffness, what Tom Bowen used to call frozen tissue, particularly in the thoracolumbar fascia. So this is this big area of fascia right over the lumbar spine, goes right down to the sacrum, and it can become quite rigid. So that's something we can actually feel. You can see it as people walk as well, because there'll be a certain rigidity in the way they walk. Because this fascia, along with other areas, what we call aponeuroses, which are these big layers of fascia in the body, act as a kind of like a springy quality to them, like a bungee. So when we walk, you can see that kind of fluidity of movement. Some people call it the spinal engine, which propels us along. So that fluidity in the fascia, that springiness, that bungee type quality in the fascia is really important. And that's something that we can really help with in Bowen, because we bring more hydration into the tissues, which is really, really important. Get that stiffness out of it. So that's something we can observe, and it's something we can palpate, because when we're working at the bottom of the spine, particularly what we call the bottom stoppers, then we can feel that. What is the quality of that tissue? How much skin slack can I get? What's the resistance in the muscle as I move over? So we can use all the Bowen moves as a diagnostic as well. And so in terms of actual sciatica, we want to ascertain where there might be some degree of nerve entrapment, because that's normally what we're talking about. And as you know, most people think of a sciatica, that they think it's possibly some disc involvement. And usually people have this kind of weird image in their mind about a so-called slipped disc. And of course, discs don't really slip at all. Or maybe the disc is slightly bulged and pushing on a nerve. And they might have been to their doctor, they might have had MRIs, they might have had scans, x-rays, etc., showing that there's something happening in the spine. There's some maybe degeneration or disc involvement or whatever it is. But of course, that does not translate to pain. You can't really correlate the results of an x-ray or a scan as to how much pain someone will experience. And that's been studied extensively. So we can do these assessments and they're very, very useful. But it still means that we have to deal with people's pain. And sometimes with chronic pain particularly, that can kind of spread. And one thing that happens, particularly in the lumbar fascia, is that you kind of, in chronic situations, you kind of get a build-up of these nerve endings, which are very, very sensitive. So you can kind of get an oversensitivity in the tissues, which means that any kind of stress, whether that's emotional, physical stress, can set off these kind of pain patterns. So with chronic pain, we're working a little bit differently. So some of the things I'd like to show you more relate to kind of the acute kind of situation. So when we're looking at the nerves down the leg, we're talking about two main nerves really, the sciatic nerve and the femoral nerve. Now the femoral nerve is the nerve that goes to your psoas muscle. It comes down more the front of the leg and is involved with things like the quads, the psoas, the adductors on the inside of the groin area. So when people come in and they say, oh, I've got a bit of numbness, pain, tingling or whatever it is on the front of the legs or on the inside of the legs, then that's usually to do with the femoral nerve. And the sciatic nerve is a bit different. Now, there are a few kind of red flags which I'd like to talk about a little bit. So red flags are where you might need to refer. So when you're talking about sciatic pain or femoral nerve pain, when people come in and they say, oh, I've got pain down both legs, That's a little bit unusual, and you probably want to suggest that they get medical attention or some other investigation. Because normally people will have sciatic pain or femoral nerve pain down one side rather than both sides. It doesn't necessarily mean there's something terrible going on, but it's a really good idea to get it checked out. So the femoral nerve is going to the front and might affect the groin area as well. And the sciatic nerve is more to do with the back, sort of going down the back of the legs and the lower extremities and to the ankle and the feet and the toes. And one way of looking at it, if you imagine our nerve pathways a bit like an animal has. So if you think of a four-legged animal and you think of the nerve pathways going down, so these are what we call dermatomes. And you might have seen dermatome charts in your anatomy books, and they look incredibly complicated in a human being, tracing the sciatic nerve down. But if you think of it like a four-legged animal, so from the sacrum, so the bottom end of the sciatic nerve comes from the sacrum, and you imagine that in a four-legged animal, that's going straight down the back, isn't it? It's going straight down the back of the leg, down towards the heel. And then if you come slightly further forward then, say to the bottom of the lumbar area, L5, you can think of that as also going straight down, but in this case, it's going more, say, to the front of the foot, say to the big toe. So that's why it's always a good idea to ask people, where exactly are you experiencing the pain? Is it more femoral nerve? Is it more the front? Is it more the back? Is it going down to the knee? Whereabouts in the foot is it, if it goes down to the foot at all? Because it can help you ascertain where you're going to work. So to give you an example, if someone is feeling numbness or tingling in their big toe, that might be related more to L5 area. If they're feeling it more to the back of the heel, well, it could be got lots of reasons why they feel it in the back of the heel, but it could be related to more sacral issues. So it's very helpful just to think of your client a bit like that. So on four legs, where do the nerve pathways come down? Because they come down kind of in a straight line. Same with the arms, actually, as well. So very useful to think of it like that. So I'm going to be showing you some assessments to do with nerve entrapment, particularly around the sciatic nerve. So the sciatic nerve is a very, very long nerve. It's also a very thick nerve. So it has several branches coming out from sort of L4, L5, S1 areas. And then it forms this big trunk of a nerve as it travels through the buttock, right next to the piriformis muscle. So when it's there, it's kind of like the thickness of your thumb. It's really pretty big. And then as it comes down the leg, it divides out behind the knee and then goes down to the foot. So when we're talking about nerve entrapment, what we're looking at really is where is it coming up against some structure it shouldn't be. So with nerve entrapment, we're talking about usually a nerve that's stretched for some reason, so it's being pulled or it's compressed. Typically, you get this in a kind of whiplash injury, for example, where someone has a whiplash and the head goes from one side to the other, and you get a pulling and a compression. So that can happen with the sciatic nerve where it's continuously pulled or continuously compressed. So that can happen in various areas which I'd like to identify. So it might happen close to the spine where it exits the spine or the top of the sacrum. And there it might be touching a bone, or it might be touching a sleeve of the membrane as it comes out, the dural membrane as it exits the spinal cord. It might be coming into contact with a disc. And then as it travels down through the fascia, it's surrounded by fascia, it's embedded in fascia, and it comes into contact with various ligaments. For example, as it comes out, it goes under this ligament here, under the iliolumbar ligament. And you can get entrapment there, which I'd like to point out to you. And then it comes down through the buttock, and it comes very close to the piriformis muscle, which is the muscle that goes from the hip and the greater trochanter to the sacrum. And there it goes very close to it. And some people actually go through the middle of that piriformis muscle and then down the leg. So show you some assessments for that. And then as it comes down the leg, we're addressing it in various ways in Bowen. In some moves in Bowen, we actually work directly over the nerves. That's in the basic work. We work behind the knee, for example. Some little moves there that affect it very directly. So part of what we're doing with this is trying to assess where the restriction is. And of course, part of the thing that we're dealing with also is where there might be lack of movement. Now, lack of movement might come from overuse, generally speaking, like someone has done too much, or they picked up something awkwardly, or underuse. So most people don't realize that the lower back particularly is very much influenced by posture. So for example, head forward posture will put a lot of strain on the back, but likewise, lifting things. Now, I mean, most people don't think if you put your arm out, to get something which you consider quite light, because a lot of people say this, oh, I just went to the bathroom in the morning, I got my toothbrush off the from the shelf, and all of a sudden my back went like this. And they think, oh, well, the toothbrush is not very heavy, but you don't think that your arm is incredibly heavy. So as I do this movement here, I'm holding about 10, 15 kilos or something in front of me. If I do this, I'm holding 20 or 30 kilos, very, very heavy. And the place that we have to maintain that relationship with gravity as we do that is our lower back. It puts a strain on our lower back. So just that act of putting the arm out, let alone lifting something, can really strain the back. So we can educate our clients like this, how to move, obviously to bend the knees, but also just to do things slowly. Because often people will do those kind of injuries when they're rushing, when they're doing things fast. And of course, when we do things fast, we put much more strain on the ligaments and structures around the lower back. So what we're going to do over this course is to really look at these kind of places in these nerve pathways of the sciatic nerve and a little bit around the femoral nerve and see how we can address it. So I'm going to show you some work around the sacrum for addressing sacroiliac joint mobility, and also around the psoas as well, which is very, very important. So when we come to the sacrum, we're looking at how much movement there is in the sacroiliac joint, because if there's not a lot of movement in the sacroiliac joint, again, the body will have to compensate for that. This is true of anywhere in the body. Where there's a lack of movement, where there's a restriction, you'll get excessive movement in other parts of the body to compensate for that. So that's true around the sacroiliac joint, and that reflects all the way through the spine. So you'll even see this reflected in movement in the neck. If there's a restriction down here, down there at the sacrum, it'll be reflected in lack of movement up here as well. So part of our work with Bowen is to get that movement back in. And I'll show you an assessment for that. We can see it when people walk, and we can do a standing assessment as well. But the restriction in the sacroiliac joints can be one side, can be both sides, and very, very commonly is also due to this kind of lack of movement or stagnation. In other words, too much sitting. They say that sitting is the new smoking, which is actually true, because too much, we're not designed to sit for hours and hours and hours, because it slows down our metabolism, compresses our sacroiliac joint, and is all in all not very good for us. So I'm going to go through a whole series of procedures that will help, and that includes work around the sacrum, the psoas, and the general alignment of the pelvis. Because when we look at the pelvis, and again, the ability of the sacrum to move, that's very, very dependent on the alignment of the pelvis. So with that, we're looking at what can happen with the pelvis. So people often come in and they say, oh, I've been told I have a leg length discrepancy. Now, that's not usually the case. Usually what we're talking about is some imbalance in the pelvis, which might look like a leg length discrepancy, where one hip is higher than the other. But there can be lots of things going on, which I'd like to explain to you. And that can have a big effect, again, on the ability of the sacroiliac joints to move. So for example, if you had a pelvis which is forward on one side or has a torsion pattern through it, that's certainly going to put strain on that, and very important to address certainly in the later stages of pregnancy, where we want the whole thing to be fluid. So we'll look at all those assessments, and we'll look at many different ways to treat that. So one of the assessments for particularly around sciatic nerve entrapment is looking at this area here around what we call the iliolumbar ligament where the sciatic nerve comes underneath there. And so we can assess for this really just through gentle palpation of the area. So to find out our location, and we can do this either lying down or standing, if I trace her iliac crests around towards the back, then where we're talking about really is from this point towards the spine is where the ligament comes. So if I was to find a position just above where my finger is there, so just above the PSIS, and I was just to place a little bit of pressure on that and just ask her, is there any sensitivity when I press there? At all, Naomi? Yeah. A little bit. And the big question is really, is it radiating down your leg or down to your buttock when I press there as well? Is it going a little bit down into your buttock area? Yeah. Okay. So that means that is positive in that place there. In other words, there's some nerve entrapment that's going on there. We'll try on the other side. So that's her PSIS. I'm just coming up above that. Some gentle pressure with my thumb. What's that like on that side, Naomi? That's actually fine. That's fine. All right. So if we want, we can just apply a short little Bowen move there to help release the pressure on that ligament. So if you imagine that the ligament is coming from that back part of the pelvis up onto the spine at that kind of an angle, well, what we're going to do here is do a move right over it in that direction, sort of up towards the level of the armpit, if you like, that direction and that direction. We're going to start on the better side first. So I can use my thumb or my finger to do this. And I'm just going to place my thumb right over the ligament first of all. And I'm just going to take a little bit of slack down, ask her to breathe. And on the exhalation, a bit of a challenge and move up and over. So you won't feel much there, but you might feel a gentle roll as you do that. So that's on the least affected side. That was the right side. So now on this side, again, to get my location, that's her iliac crest coming down towards the PSIS there. We know the ligament is coming up here like this. So again, we're going to use our thumb. And again, we can just take the skin slack down so it is an angle here. Ask her to breathe and move up and over in a direction that's superior and lateral up towards the armpit. So it'll help relieve the pressure on that sciatic nerve as it comes out there. So for the work around the psoas, the prerequisites for that really are the work around the back, the moves particularly up the spine because the psoas is attaching onto the lumbar vertebra there. And it's also nice to do the front work around the diaphragm because of the continuity of the diaphragm with the psoas at the back and down through the abdomen. So I like to start by working at the diaphragm. So we'll trace the ribs here, coming up towards the base of the sternum, which is here, and her xiphoid process, which is just at the base of the sternum there. So I'm going to have my holding point just beneath the xiphoid, and I'm going to do these lateral moves over the edge of the diaphragm. So halfway along between that holding point and the corner of the rib there, I'm going to place my thumb just beneath that rib. We're going to ask Naomi to breathe, and we're going to take the skin slack up, turn a little bit, and come up and under the rib. A nice, easy move on that full exhalation with my thumb. And the same thing now on the right side with my finger. Ask Naomi to breathe in and all the way out. And as she breathes out, we'll take the slack, we'll turn, and we'll come out laterally. And then the last move, we want to make sure that we can get enough skin slack up towards my holding point. So we'll ask her to breathe again. And just hold your breath for a sec as we take that skin slack up towards that holding point and then down towards her navel. So that's the prerequisite for the next bit around the psoas. So we're going to work on Naomi's iliacus, which is part of the ilia-psoas group. Now the iliacus is really important because it helps maintain positioning really with the pelvis and the various two ilia the relationship with the sacrum, etc. So the iliacus is attaching onto the inner rim of the ilium here on the left and right. And where we can get to it is actually, we're going to do a very gentle move just on the inner rim of the ilium here, around the ASIS, just there. So we're going to find that now on Naomi. Good, so what we're going to find here is her ASIS, which is the front part of the ilium. We're going to come a little bit medial to that, onto the soft tissue. And we want to take a bit of slack down, hook in a little bit, and come up and follow the line of the ilium as we do that. We want to do that on her out breath. So we'll ask her to do a really good breath in and all the way out. And as she breathes out, we're going to take the slack down, hook back a little bit, and come right over the edge of the iliacus as we do that. So as you do that little move, you'll feel a kind of ridge of muscle, which can be a little bit sensitive there. Then I'm going to walk round to the other side. So for her left iliacus muscle, again, we're going to find her ASIS, which is the front of the pelvis there. We're going to come medial to that, onto the soft tissue. And we're going to take the skin slack down on her full exhalation. So we're going to ask her to breathe in. And as she exhales, we're going to take the skin slack down. We're going to hook back a little bit. And as we come back, we're going to follow the edge of the ilium, and we'll feel a little roll of the edge of the iliacus as we do that. Great, and having done that, we definitely want to wait now. We've done the psoas work and the iliacus work, which work together, and then we'd like to leave her for at least 10 or 15 minutes after this, just to relax.